Welcome to everyone to our today's webinar, AI in Pediatric Radiology. I'm Alessia Guarnera, Secretary of the Educational Committee of EuSoMII, and it's my pleasure today to have you in this wonderful webinar that I will moderate together with Professor Lene Laborie from Auckland University Hospital of Bjerke. Thank you very much, Lene, for being here from the ESPR. So this joint webinar, EuSoMII and ESPR, for us is extremely important. Why speaking about AI in pediatric radiology? This is crucial because children, unfortunately, are really underrepresented in literature. And it is very, very important to find emerging tools, to use AI to improve care and improve safety for our children. So today the webinar will be divided into three different parts. We will have two fantastic presentations from our speakers, and we will have question and answer time together. So as you can see here, to obtain credits, you can simply have a look and scan this QR code. After scanning this QR code and after the webinar, you will have the possibility to reply to our answers to the survey, to fill the form and receive credits. No worries, if you're not able to scan, you will receive an email after 24 hours and you will have 1 week to reply to the survey. And I will show this slide at the end of our webinar. So don't worry at all. And I do not want absolutely to lose time. I'm very happy to introduce our first speaker, Professor Brendan Kelly, who is adjunct professor at the UCD School of Computer Science in Dublin, Ireland, and is the Aspire Fellow in Pediatric Radiology Children's Health Ireland. Thank you, Brendan, and please, it's your time.
Thank you so much for the kind introduction. That's great. I'll just perfect. And I can share. Great. Thank you so much for that kind introduction. I really, really appreciate it. My name is Brendan, and it's really, I'm very grateful for the invitation to get to present on a topic that's really close to my heart. We're going to talk about AI in pediatric radiology, and particularly multimodal AI today. And I'm going to talk about the technical aspect of that from the EuSoMII side, from the EuSoMII point of view. I'm a Pediatric Radiology Fellow in Dublin, Ireland, as was said, and I'm a lecturer assistant professor in the School of Computer Science in UCD. So we're going to talk about the learning objectives we're hopefully going to get through is when we talk about a little introduction to artificial intelligence, but then I'm going to get into multimodal AI and how it can be a little bit different, talk about some applications, risks, benefits, and limitations, and then at the end, hopefully give some sort of practical elements if we were going to roll this out and to do it and to implement. So I'm going to start with a little introduction to artificial intelligence and talk about the importance of data and definitions. So we know that there's a huge amount of radiology and multimodal data that exists in a hospital, but sometimes all of it isn't accessible and isn't easy. And I like to show this example as an example of when it can go wrong, that this gentleman was invited for a vaccine in the first round of vaccines back in the COVID-19 pandemic because the NHS thought he was 6 centimeters tall. Instead of inputting 6 foot, someone input 6 centimeters and his BMI ended up coming out in the hundreds and he was invited in the first round. And that's just to say that there's a difference between different types and different levels of quality of data in healthcare from, a level D data, which is inaccessible in an unknown format. And the process of taking that to contextualize, analyze it, and task-ready data takes, a huge amount of effort. Wilmeke et al. Produced this paper back in 2019, and it discusses the process of processing this data, and you can see all the different steps involved. If I just talk about the data de-identification for a second, after you've skull stripped and registered and subtracted all the images, put them into the same feature space, you might take the current from the prior and do some segmentation. It's a huge amount of effort that goes into these things, and that's only one step in this process. So it's important to realize that when you're undertaking one of these projects, that the data is just one step along the way. So what is artificial intelligence? We know that it grew out of work in computer science, that it new capacity for computers, and it came out of applications that can't be programmed by hand. So if you can describe a task in code, it doesn't need artificial intelligence, but something that's more complicated, like say trying to fly an autonomous helicopter or handwriting recognition became the kind of area of machines. And artificial intelligence is so broad, but we can structure it down. Machine learning is a subset, which are machines that can learn to without explicitly being programmed to do so. Deep learning then uses, textures and underlying features. But we're going to talk today about another subset, which is multimodal AI. And it's of particular importance, I think, AI in general to pediatrics, as was said in the introduction, because the amount of clinicians trained in the interpretation of pediatric data, unfortunately, just can't keep pace with demand. So artificial intelligence is one way that we can help with this supply-demand issue. Okay, now, finally, let's get into multimodal AI and how we can talk about multimodal AI. So the key concept behind multimodality is that we are using different information streams about the same patient. So it can get a little bit tricky when you consider, different MRI sequences and things like that. So as distinct from multi-channel AI, which might be using like a T1 and a T2 of an MRI, multimodal AI explicitly uses different types of data. So that might be an MRI plus a text report and some kind of a lab report. If we zoom in on our different kinds of data that might be available, you can see that we're talking about an integration of imaging data, maybe with other omics data, such as epigenomics or genomics, and trying to put that all in with EHR data, lab data, and bringing all these different elements of healthcare data together. And it's been an interesting journey when you follow this along the developments and the techniques that have come along the way. So, I mean, traditional machine learning before the 2010s was what was going on, and it was only really with the development of convolutional neural networks and AlexNet winning the ImageNet challenge back in 2012 that computer vision to human level performance became possible. But since then, we've just accelerated, and things are getting faster and faster and more complex every day. Um, 2014, 2015 brought CNNs and biomedical imaging. When I started my PhD in 2016, 2017, people were talking about data-driven imaging, so radiomics and radiogenomic data. 2017 brought the introduction of the transformer and enabled the attention mechanism of the transformer enabled much better processing of texts. So now we have excellent image-based recognition, we have excellent text-based recognition. And those were combined in 2021 with vision language models, and these have continued to advance with even now foundation models and agentic systems becoming more and more prevalent. And I'll talk more about those as we move through the presentation. But there are downsides as well to multimodality. So if you were to have a very simple AI experiment and you wanted to see if a breast tumor was benign or malignant, you could maybe, and you had just based on its tumor size, that would be a one-dimensional problem. But in the real world, things are more complex, and maybe we'd get a more accurate prediction if we had a two-dimensional model that considered age and tumor size. But for multimodal AI, we're dealing in many dimensions. Three-dimensional data is easy enough to kind of conceptualize. Four-dimensional data, maybe the color has some sort of meaning, but as we move up into more and more complex data, the dimensionality becomes more difficult to conceptualize, and we need more sophisticated computer algorithms to deal with this. And this is compounded by the fact, the human genome has something like 3 billion parameters, and it gets more and more, we need more and more computer processing to manage these things. And high dimensional data poses its own challenges because a lot of algorithms are based on the relationship between two things in a feature space. And in very high dimensional data, the space itself becomes even more complex. Now we're going to move on to the technical aspects of how we actually deal with our multimodal data. We've processed it, we've accessed it, and then we have to think about how we're going to fuse that data together. And classically, there are three ways of going about this. You can fuse them right at the start with early fusion. You can fuse them somewhere in the middle using some sort of encoders and decoders, or you can fuse them at the very end. So you might have a system that does just radiologic data and a system that does just genetic data, and then they'll give an output and we can fuse them at the very end. All these options have different pros and cons, but it's important to realize that the more interconnected a model is, the more difficult it will be to deal with sparse data or missing data particularly. So if you don't have if you might maybe have 100 CTs, but only 50 pathology samples, this is something that you need to build in at the start. Um, and just to give another way of looking at that same data, the different types of fusion, to just show the options of starting intrinsically multimodal with all of the data, fusing it a little bit later on, or fusing just before the final output with separate outputs of the models that you're ensembling together. Different model families have proven to be more successful in multimodal work. If you're working with text data, transformers are certainly the gold standard. If you're talking about relationships between data, particularly relationships in a feature space, graph neural networks have shown to be very, very useful for looking at, like, for instance, measures of similarity. But the trade-off is that they can be a little bit less explainable, and they take a lot of skill and kind of, know-how to get going. Whereas most recently, vision language models and foundation models, which are akin to the ChatGPT style models that we use frequently, they are coming more and more popular, more and more feasible, but are very big and costly to train. And I'll talk about that in a moment. So I guess a practical rule would be to pick the simplest architecture that matches the task. And if you have and the data availability, and if you have incomplete data, sort of the more separate models that are fused at the end might be more successful. So I'm just going to move now to talk about the practicalities of training these models. So we've talked about the dimensionality, the amount of data that's needed to train the models, and now I'm going to just bring you on to the nitty-gritty of trying to get these things to work. So back in 1998, Jan LeCun, he and his lab came up with the Lene. And you can see that this was the amount of RAM and the amount of training data that you needed to do these. It was a reasonably small GPU and 24 gigabytes of RAM. This is the sort of thing that even could be run nowadays on someone's personal computer. Things got very complex very quickly, though, with AlexNet, which was the first convolutional neural network that showed to be better at identifying cats and dogs than humans. In images, and remnants and sort of children of this sort of network have become very, very popular and are what's widely used today in radiology applications. It's gone from needing, it needs a little bit more training space because the number of parameters goes from 60,000 parameters in the model to 60 million parameters in the model. We then move on to the EuNet, which is probably the most popular segmentation algorithm, and variants of the EuNet are still state-of-the-art and used today. But now we're reaching 80 million parameters, and now we need an 8 gigabyte GPU, and you're moving away from what's possible to be done locally and needing kind of more expertise and more machinery. Transformers that enable large language model processing, again, is the same problem. We need more parameters and a higher GPU requirement. Vision transformers then, which combine both, we're now getting into 2020 in the age of very, very complicated and very computationally expensive requirements with large GPUs and hundreds of millions of parameters. CLIP, which is a more advanced kind of vision language model, shows the ballooning and the exponential growth. So if you want to get any more improvements out of these models, they're just getting bigger and bigger. Stable diffusion, which people use to generate images, has cracked the 1 billion parameter benchmark with GPU requirements. So these need to be done not even in university GPUs, but in centralized supercomputers. And the most advanced vision language models now are even higher than that. ChatGPT-4 even higher, and the highest performing GPT models now are estimated, even though this is closed data, to have hundreds of billions of parameters and a GPU requirement of terabytes. So this is things that need to be done in supercomputers and that not even most universities have routine access to. So now we'll just move on to applications, and I'm going to deal with this quite lightly because Diana is going to talk about this in a little bit more detail. But the whole point of why it's worth using this multimodality is that when you want to predict disease outcomes, you're going to get a bit of a performance boost by using the multimodal data most of the time. Kind of a literature review, which we'll talk about later, has about a 6 percentage point increase. But this data tends to be kind of closed and kind of not prospective. Most of the papers only have internal validation, and most use public source data as opposed to real rough and ready out in the wild data. However, the literature clearly shows an increasing trend in publications in this field, and also that radiology and text are leading the way as the modes of this multimodal data. So for that reason, when we look at trends of data modality in these papers, we get through to, radiology models combined with text and maybe with omics models is a really fruitful area for research and hopefully one day clinical translation. And that means things like image and text reports or images and clinical data, as well as longitudinal multimodal studies that are particularly relevant in children because of the growth and development and how children change over time. These are going to be high-value multimodal use cases going forward. So there are lots of potential benefits. They behave more like multimodal models behave more like we do in clinical practice because it uses multiple sources of data, be that age, labs, or treatment status, and it can outperform single modality methods. However, it's harder to find paired data sets. So often in pediatrics, we're working with rare diseases. And if you combine that you need different modes of data for each disease, this gets more and more disparate. And furthermore, because you need all these kinds of data and because the levels of computational demands are higher, it can be harder to find bias can become more of a problem and it can be harder to explain the models because the interactions between the modes are often as important as the actual individual data points themselves. Um, Governance is also difficult because you need to have an extra layer of communication between these devices. So I think Felipe, who's a Brazilian radiologist, many of you might know, he devised this. And I wonder if any of you were feeling at that state of worry about AI taking your job. But, I worked under Kurt Langos in Stanford, who said that AI won't replace radiologists, but radiologists who do will replace those who don't. And I still, I really believe in that. This has been going around for a while, but I think it's really, accurate. As I'm a radiologist in my, in traffic driving to work, I kind of think back and being like, it's been repeated again and again that AI will replace us. That was the quote from Geoffrey Hinton, that a radiologists were like Wile E. Coyote, having been already off the cliff, but not yet looked down to see that he was going to fall. But when he visited my university last year on his kind of tour around winning the Nobel Prize, I got the opportunity to interview him. I wrote about it in European Radiology here, and he admitted that he was wrong. And the reason why he was wrong is that he thought that a radiologist only looked at images. He thought that, all we do all day is write sophisticated captions based on imaging. But, the role of radiologists today is much more than that. We don't just write sophisticated captions. What we are is we're information dealers, Our clinicians, they operate in an incredibly uncertain environment. They don't know what the diagnosis is. They might be worried about the child. There might be pressure from the parents, all these things. They come to us with a diagnostic dilemma, and we have to perform and interpret diagnostic tests for the purpose of reducing that uncertainty. So the role of the radiologist of tomorrow isn't writing sophisticated captions, but it's the quarterback or the fulcrum, and yes, maybe even the wizard of AI-enabled integrated diagnostics. This is the future that we want to bring everyone along to, pulling together these different modes of data. And personally, I can't think of any specialty that's better placed to do this than radiology, because it's what we do every day. We take different modes of data and we put it together for the purpose of reducing uncertainty. And thankfully, there are really exciting projects that are starting on this. For instance, I'm really, really lucky to work in Children's Health Ireland with the Magic Eye project, where we've performed whole genome sequencing on every child with a new cancer diagnosis in Ireland and are developing digital twin solutions to try and do longitudinal follow-up and outcome prediction. And then, of course, centered in Diana's university, we have Primage, which does something similar for neuroblastoma and is a huge European-wide multi-institutional collaboration. So these projects may be still in the research phase in pediatrics, but are really happening. Which brings us almost to the end of the talk, where I'm going to talk just briefly about deployment. And unfortunately, while multimodal AI does bring a lot of benefits, there are also some associated risks. And the core of the cause for these risks is that integrating new systems can introduce new points of vulnerability. So every time we add something, we're increasing the potential attack surface. If you can visualize it as a 3D surface, every time we add in a new factor, we have more points of vulnerability. So the more inputs we put in, the more untrusted content paths that we're leaving ourselves open to. We also leave ourselves open to cross-modal prompt injection such that if we have multiple streams of data, where our system is only as strong as the weakest link in that chain. And the linkage itself comes with identification and de-identification risks because to be able to link data from one patient across different modes, there needs to be some kind of a thread that connects them, and that could potentially be used to re-identify a patient. So in this way, all of the medical imaging risks that affect cybersecurity still exist with multimodal, but they're exaggerated and compounded and feed potential other attack surfaces. So it's really important to think about this with a safe evaluation pathway before any of this could be implemented clinically or integrated clinically. So it's really important that a specific intended use and a specific plan is made for what's trying to happen. What are we trying to achieve? Who's the target population? And are we only applying it to that? Benchmarking is incredibly important because it needs to be compared against unimodal baselines because there are risks with multimodality. So we should only use it if we're sure that it's better than single mode data. It's important to stress test this to make sure it generalizes and also to evaluate it afterwards because performance can shift and performance can drift. And this is made, all the more complicated because even if there was a problem with one of those many streams of data, it can have downstream effects. And some sort of a silent or sandbox style testing is really definitely required. Particularly, for pediatrics, it's recommended that we should do this, with predefined subgroups for age. So a real integration pathway for peds would look like, taking our data sources, whether that's RIS, PACS, omics reports, whatever it might be, doing really efficient data engineering. So making sure that we only include the modes of data that actually contribute to a more accurate diagnosis and combining them where necessary to reduce the dimensionality and the problems with that we discussed. We then need some sort of a multimodal service that can use some sort of an autoencoder to combine the data. And oversight for all this there needs to be some sort of a kind of a clinical eye, casting an eye over all of this. So making sure that the data is complete, making sure that it's plausible. I mean, does this output actually make sense? And so that we can contextualize it and really explain the uncertainty that comes out of these models. So I'll just conclude with that to show that what's going on with these models is very different. While it's exciting, it's very different from what we do every day. And the radiologist of the future, isn't a machine with primacy over anyone or making decisions independently. We're certainly not there yet. Just because you liked A Bug's Life doesn't necessarily mean you'll enjoy The Human Centipede. I personally would be offended if someone sent me any of these love hearts for Valentine's Day. And still, to this day, the best convolutional neural networks in the world can't tell which of these is a sloth and which a pain au chocolat. So for that reason, the major societies are still recommending against autonomous AI. So I hope that you'll, agree with me that now we understand a little bit more about what's going on under the hood in these models. Reports of radiology's demise, to paraphrase Mark Twain, I think are greatly exaggerated. So just to summarize, multimodal AI takes different types of information and is closer in that way to how radiologists reason than imaging only or pixel-based AI. It's important to think about what's being fused, when it's being fused, is it early, middle, or late, and what happens if there's missing data. For pediatric radiology, the opportunity is greatest when age, context, and change over time are important, and that's really, really frequently in the situations we see in clinic. But it's also important to have strong governance and radiologist oversight because these modes of data don't necessarily, there's a huge amount of shift, there's a huge amount of change, and we have to make sure that if we're adding something that could potentially cause harm, that there's a significant benefit associated. So we'll get into the discussion afterward. But I think like an interesting question isn't, how many types of data can we fuse, but does this extra context actually improve decisions safely for children? So thank you all so much for your attention. I really, really appreciate it. Thank you for listening. There's some references here. My contact details, my email is brendan.kelly2@ucd.ie, and I'm very happy to be contacted from it. That QR code will link to my LinkedIn. But I, probably like most of you, I'm really looking forward to hearing from Deanna. So I'm really excited to see what she's going to talk about when it comes to the clinical side of all this sort of techie stuff. So on to you.
Okay, thank you so much. Thank you so much, Dr. Brendan Kelly, for this great talk. And as you mentioned, we'll now move on to the second speaker of our webinar. We are very pleased to welcome Dr. Diana Veiga-Canuto. She's a pediatric radiologist at Hospital Lene in Valencia, in Spain, and she completed a clinical fellowship in general pediatric imaging at the Hospital for Sick Children or Sick Kids in Toronto, Canada, and obtained her PhD at the University of Valencia in Spain. Her thesis focused on MRI biomarkers of biological aggressiveness in pediatric neuroblastic tumors within the framework of the multicentric European Primage project that Brendan also mentioned. She completed her training with educational stays at Boston Children's Hospitals, Harvard Medical School, US, and Hospital San Juan de Dios in Barcelona in Spain. And her main interests are pediatric oncological imaging, advanced MRI biomarkers, and the integration of AI into pediatric radiology. So please, Diana, go ahead.
Sorry, 1 second. I'm just sharing my screen. Okay. So thank you so much. Good afternoon, everyone. Thank you for this warm welcome. As Lene said, my name is Diana Veiga-Canuto. I'm a pediatric radiologist in Valencia, in Spain. And I'm truly honored to be here at this EuSoMII and ESPR joint session. I'm very happy to share it with my colleague, Brendan Kelly. It was really nice, a really nice lecture. And I'd also like to thank our moderators, Alessia Guarnera and Lene, the chair of the AI task force at ESPR, and also to EuSoMII for inviting me and for organizing this nice session. So I'm really very happy to represent ESPR today and to share with you some perspectives on multimodal AI in pediatric radiology, looking at its clinical applications, opportunities, and challenges. I hope this session gives you a sense of what's happening in the field from a patient-centered practical perspective, complementing these technical insights that Brendan already provided. So by the end of this lecture, I'd like you to understand the principles behind multimodal AI and, more importantly, its clinical benefits. Second, I want to get an overview of the current clinical landscape in pediatric radiology, including both conventional machine learning approaches and the emerging foundation models, but from a clinical point of view. Third, we will try to recognize real-world applications as decision support or workflow optimization systems. And finally, to discuss the limitations and the responsible implementation, what we need to consider ethically and practically when applying these tools in pediatric practice. So we are going to talk about multimodality, but the truth is that historically the dominant paradigm in clinical artificial intelligence in pediatric radiology have been unimodal models. These predictive models use a single data source at a time, one modality, one repository, which makes them simpler to develop and easier to manage. In pediatrics, we see this across different domains. For instance, in laboratory-based models that can predict mortality or disease progression, for instance, in pneumonia. There are pathology models for distinguishing histology of different cervical lesions. We have imaging models for detecting fractures or tumors. And also in genomics, there are models for rare diseases, although they are more established in adults. So this sets the stage for understanding why moving towards multimodal approaches can add value by integrating these separate data streams into a more comprehensive clinical picture. Because the reality is that while unimodal models can perform remarkably well, they capture only a simplified slice of the clinical reality. Patients, and especially children, are complex. Take, for example, a 1-year-old with abdominal distension and elevated urinary catecholamines. So making sense of the whole picture requires integrating multiple types of information. Clinical decision-making is inherently multimodal. We rarely rely on a single data point. Instead, we combine laboratory values, imaging findings, pathology, genetics, and clinical history. Some diagnoses can be made from one threshold value, but most require a constellation of findings, often integrated. Traditionally, this integration happens in multidisciplinary boards. Each specialist contributes their modality-specific expertise, and together we reach a decision. This approach improves care, but it's not infinitely scalable, which is exactly where multimodal AI can add value. Because the amount and diversity of data continue to rise. Not only are there more data points, but the complexity and rate of treatment options are increasing as well. Selecting the optimal therapy has become more challenging, highlighting the need for a data-centric integrated approach. The question then becomes, how can we combine all of this information effectively to support clinical decision-making? So this is where multimodal AI comes in. It aims to model this integration computationally, combining different types of data into a unified predictive framework. In a sense, it tries to do what clinicians already do in multidisciplinary boards, but at a scale. So what are multimodal AI models? We already saw it with Dr. Kelly's lecture. They are artificial intelligence systems that integrate multiple types of medical data, imaging, clinical records, labs, genomics, to support comprehensive patient assessment, accurate diagnosis, and individualized treatment planning. Unlike unimodal AI, which uses only one data type, multimodal AI leverages complementary information across sources, producing clinically relevant and actionable outputs. And actually, an overview of multimodal AI applications showed that these models achieve a mean improvement of 6.4% in the area under the curve compared to unimodal approaches. While this may seem modest, even small gains in predictive performance can have meaningful impact on clinical decision-making. Multimodal AI is therefore emerging as a key tool for precision medicine. However, as we mentioned before, this style focuses on the clinical perspective on multimodality. So when we look at the literature, it's clear that clinical translation remains a little bit limited because only 37.6% of the studies about multimodal AI in PEDS are published in clinical-oriented journals, and none of the models have received FDA approval to this date that I'm aware of. So this highlights a major gap between technical development and real-world implementation. If we look more closely at the clinical landscape of multimodal AI, a large scoping review analyzed more than 400 multimodality studies based on convolutional neural networks. In this review, multimodality was defined from a clinical perspective as the integration of data originating from different medical specialties. One key finding is that radiology plays a central role in multimodal AI. Radiology was used in 30% of multimodal models, making it one of the most frequently included data types alongside clinical text. And as we saw before, the most common multimodal combination was radiology and text, reflecting how imaging findings are interpreted in conjunction with clinical information in real-world practice. This highlights that radiology is not peripheral, but rather a core component of multimodal clinical AI systems. So when looking at clinical applications, the nervous and the respiratory systems clearly dominate. Most models focus on diagnostic tasks, followed by survival prediction and prognosis. They target specific clinical questions in areas like neurodegenerative diseases, respiratory conditions, and oncology, showing that multimodal AI is tackling meaningful problems. However, a closer look reveals an important gap. Most models have been developed in adult populations, and pediatric populations are rarely represented as a distinct category and are often embedded within broader groups rather than being a primary focus. In this review, including 128 articles, only 6 pediatric studies were included. So pediatric applications, as we said, remains a little bit underrepresented. This does not reflect a lack of clinical need, but rather this highlights that multimodal AI in pediatric medicine remains underexplored. Pediatric-specific datasets are scarce and often small, as Dr. Guarnera said at the beginning of the lectures, and there is limited anatomical and developmental variability representation. So this actually represents both a challenge and an important opportunity for our field. So To better understand where pediatric radiology currently stands, it's helpful to look at recent evidence. A comprehensive 2026 review analyzed almost 800 AI studies specifically focused on pediatric radiology, providing a clear picture of the current landscape. What this review shows first is how AI is being used in pediatric radiology. The vast majority of studies, over 90%, focus on image interpretation and diagnostic tasks. In contrast, far fewer studies address all the important areas such as image quality enhancement, for instance. So this indicates that pediatric AI research remains largely centered on replicating or supporting the radiologist's interpretative role. When we look more closely at the clinical domains, research is concentrated in a limited number of subspecialties. The most common clinical applications include bone age assessment, pneumonia detection, or brain lesion identification. So taken together, these findings show that pediatric AI research is growing, but remains focused on a relatively narrow diagnostic tasks and specific clinical areas. And more importantly, most of these applications rely on single modality imaging data. This again highlights a major opportunity for future innovation in our field. Having reviewed this current landscape of AI research in pediatric radiology, the next question is how multimodal AI can be implemented in practice to support clinical decision-making. So to illustrate this, I will show a real-world example from pediatric oncology, the PRIMATCH project that Brendan already mentioned in his lecture. So this project finished a couple of years ago, and I was involved during the process of developing the whole project, and we developed a platform that integrates imaging, clinical, and molecular data. So the process begins with MRI acquisition, the MRIs that we acquire in the clinical practice, and we did different pre-processing processes of the images and tumor segmentation. So from these images, different quantitative biomarkers were extracted, including radiomics and deep learning features. Then all these features were integrated with clinical, with genetic, with pathological variables into a unified multimodal framework. And this integrated dataset enabled us to develop predictive models for risk stratification and outcome prediction. In this case, for instance, we tried to understand how these tumors behave and to extract the overall survival of these tumors based on imaging and clinical data, genetic data, and pathology. But beyond prediction alone, an essential question remains here. So how can these models be translated into clinically interpretable tools? This is where explainable AI becomes essential, and also in every field of AI, but also it's very important in pediatric radiology to understand what actually we are doing. So we used these SHAP values that allow us to quantify the contribution of each variable to the model's prediction for an individual patient. In this example, we can see how here we have different variables, and we can see how different imaging biomarkers, and for instance, skewness, together with different clinical and molecular variables, contribute differently to the predicted risk. These predictions can then be translated into clinical decision support tools, such as this risk panel that we extracted, which provides an individualized risk estimate based on the integrated multimodal profile of the patient. We are currently working to implement this multimodal approach in our clinical practice and translating predictive models into tools that can support patient-specific decision-making. Our second use case highlights the broader potential of multimodal AI beyond the individualized risk prediction. This system can support multiple stages of pediatric care, from patient triage and protocol selection to image acquisition, optimizing the workflow and improving the outcomes. By integrating different types of data, AI can enhance the accuracy and adaptability of the triage and diagnostic decisions. For instance, combining imaging and laboratory and other clinical data, pediatric AI can assign urgency more precisely, which is especially valuable in emergency or in high volume settings. So pediatric multimodal AI has multiple applications. So far, we have seen how traditional machine learning and convolutional neural networks can integrate multimodal data to support clinical decision-making in pediatric radiology. Yet the field is evolving rapidly. And as we saw in Dr. Kelly's lecture, a new class of AI, the foundation models, is emerging. These are large-scale pre-trained models that are capable of learning from diverse datasets and can adapt to a wide range of clinical tasks with minimal additional fine-tuning. In pediatric radiology, they can support pathology detection and classification, lesion segmentation, report generation, and even visual question answering. This table summarizes the emerging applications of foundation models across key radiology tasks. So traditional AI often struggles with small data sets, poor generalization, or task-specific limitations. Foundation models, by contrast, leverage multimodal embeddings or transfer learning to improve performance across several tasks. In pediatric radiology, as we said, these advantages are especially valuable given the scarcity of pediatric-specific data and also the anatomical variability across ages. You can find here some of the specific pediatric radiology examples that are being developed or have been developed recently that illustrate how these models are starting to translate into clinically relevant tools, for instance, for classification or detection of pneumonia or for lesion segmentation. So, having explored the clinical potential of multimodal AI, let's now look at the other side of the coin, the challenges, the limitations, and the ethical consideration that come with its implementation. While these systems can support decision-making, improve workflow, and enhance patient care, translating them into pediatric radiology is not straightforward. One major challenge is the lack of representative pediatric datasets, as we said. Most AI models are developed and validated in adults, yet children have distinct anatomy, physiology, disease patterns. So this raises concerns about the generalizability, bias, and ultimately patient safety, which is very, very important in this case. So beyond data limitations, there are also practical barriers. Integrating AI into existing workflows, ensuring interoperability with hospital systems, and navigating regulatory and infrastructure requirements. These challenges highlight the importance of clear principles for safe implementations. Transparency and explainability are essential so that clinicians can actually understand and trust the model outputs, while human oversight must remain central to clinical decision-making. At the same time, robust governance and continuous performance monitoring are needed to ensure safety and protect sensitive pediatric data. Despite these challenges, multimodal AI also offers important opportunities, of course. By integrating imaging, clinical, and lab information, these models can capture a more complete picture of the patient. This has the potential to reduce bias, improve representation across population, and support more personalized and equitable care for children. To realize this potential, several elements are key. The development of pediatric-specific datasets, strong multidisciplinary collaboration between clinicians, data scientists, and regulators, and careful stepwise implementation with ongoing monitoring and, of course, education. So, having explored the landscape of multimodal AI in pediatric radiology, we can conclude that multimodal AI combines diverse clinical, imaging, and molecular data to improve diagnosis, prognosis, and personalized care in pediatric radiology. Most multimodal AI research is adult-focused. Pediatric applications remain limited, but emerging foundation models offer promising new opportunities. From clinical decision support and triage to workflow optimization, multimodal AI is beginning to support practical patient-centered care. And finally, safe integration requires pediatric-specific validation, human oversight, ethical governance, and continuous monitoring to ensure equity and reliability. Thank you again for inviting me today, and thank you all for attending to this lecture. Thank you.
Thank you so much, Diana Veiga-Canuto. That was really, really nice. I think with Alessia, we'll just move straight on to the questions and answers section. Please, all of you, don't hesitate to type questions into the chat or the question and answers feature, and then we'll just move along. Alessia, would you like to start with at least the question for Dr. Kelly for the first talk?
Sure. So, Brendan, this is a very clever question. And also, Diana a little bit spoke about that, but I would be very happy to know your insights. Do you think that ethical concerns could impact the AI research in pediatrics? Which are the main obstacles?
Thanks very much, and thanks, Roberto, for the question. Yeah, I mean, I think if you think about the development of any AI application, and Diana and I have been fortunate to be involved in these things, any AI application is by definition a multidisciplinary feat. No one person is going to ever be able to do the entire thing on their own. And it's also really important to remember why we're doing this fundamentally, because we're not doing it for ourselves or for intellectual curiosity. At the end of the day, it's about patients and the children we look after and their families. So if you think about that chain of all the different people who are involved in creating an AI product, you then have to think of the role of a clinician within that paradigm. And a big part of our role is to make sure that the normal medical ethics principles, things like first doing no harm, are maintained. So you think about, companies like Facebook or big, I shouldn't single out Facebook, but big Silicon Valley companies, traditionally, the motto there is move fast and break things. And there's a tension between moving fast and break things and first do no harm that I think is really important, and we remember that our role in the process. Another really important thing specific to pediatrics is that the data sets tend to be smaller and the diseases often are rare diseases. Like all childhood cancers are rare diseases if you want to look at them that way. So that means that if we want to use big data on kind of smaller data, that cross-institutional collaboration is really important. So this is super true in cancer imaging trials or drug trials for cancer therapies, but it's also true for developing AI. So when we want to link multimodal data and when we want to do it across multiple sites, all those things add extra ethical implications and boundaries. But the motivation to positively impact these things, like predicting childhood cancers better, that Diana really, really nicely illustrated. The motivation is so strong. So there are ethical problems with AI, with multimodal AI, and these things are compounded in pediatrics, but that doesn't mean that we don't do them. It means that we look at them through new eyes, with a new lens, as different ways to approach a problem. And I think the main obstacles when it comes to ethics as well is trying the extra complications with dealing with the small data set. So I think the small numbers and the pediatrics issues overlap, but that's not to say we shouldn't do it. It's just from a research point of view, it's an interesting challenge that we have to overcome.
Thank you very much, Brendan. This is a very insightful answer. So thank you very much. I will invite Lene to ask a very nice question to Diana because...
Yes. Thank you. So first of all, thank you to those of you asking questions. The next one will then be for Diana. So Diana, how straightforward do you think it would be to bring the neuroblastoma decision-making workflow into the day-to-day clinical practice? Also a very good question, so I'm looking forward to the answer.
It's a really, really good question. Thank you so much. So yeah, actually, it's one of the things we have to be more concerned about because, as we saw in the lecture, a lot of tools are developed, but none of them is yet approved. But the FDA or other regulating agencies. So we are developing tools, but we are not being that able to apply them into our clinical workflows. So integrating these neuroblastoma decision support models into clinical practice is promising, of course, but it's not that straightforward because technically it's feasible, but it's a real challenge to validate and integrate it into the clinical workflow. As we said during the lectures, in pediatric oncology, even more, we need robust multicentric data, we need external validation, and we need tools that can be easily used within our reporting environment, within the radiologist reporting environments. So if these conditions are met, the models can realistically support risk stratification and treatment planning in the near future. But the truth is that there are some barriers, regulatory barriers, governance barriers with the data. So it's not that easy. Actually, for instance, in the primates case, we developed these tools that worked nicely during the project. And now we are trying to integrate them into our clinical workflow. We are currently working on it with the RIB approval and everything. So I don't have results yet, but hopefully we will work with them and we will be able to validate them and in the future integrate them into our clinical workflow, and yeah, to be able to use them, because it's what we were saying. We develop these tools and sometimes it's really difficult then to work with them in our normal workflow. So thank you for the question. It was a really nice one. Thank you.
And can I just say briefly
Sure.
on that there's people out there who kind of talk about oh, we want to work with other people, or we want to do multidisciplinary collaboration, or we want our tools to be externally validated. But as someone who's a little bit later to this game than Diana is, I know from personal experience that the Primage group really do want to help. And you know, part of the pilot data for a grant that I'm writing currently comes out of a collaboration with them. So we're really fortunate to even though we are at the early days, the people who are doing this, maybe just because they're pediatric radiologists, you know, they're nice people, they want to help, they want to make the you know, to move this to the next stage. Nobody does this stuff, you know, to write an academic paper that nobody's going to read. And you know, I'm just really fortunate to sometimes get to send a message to Diana and actually get to do these things and start to do some multidisciplinary collaboration.
Indeed.
Wonderful. Well, thank you, both of you, then for answering this question. And I think actually the two next questions are kind of two questions built into one. So I think maybe I'm tempted to ask you, Diana, giving a quick answer to the question, and then we'll pass it on to Brendan. And the question is actually, if I merge the two, how do you think we can build large data sets? For instance, the one asking the question has read that people are just using images they find on Google, for instance, neonatal abdominal radiographs. And then the next attendee asks a similar question: with global workforce issues in pediatric radiology, will putting these pediatric data sets together going to be difficult? So I think those can be viewed together, and I'd like to hear both of you, the take on that one. Thank you.
Sure, thank you. Thank you for the questions. So yeah, actually building large pediatric datasets is definitely one of the key challenges in pediatric radiology AI research, because many pediatric diseases are relatively rare and single institutions usually don't have enough cases to train robust models, and even less to validate these models. So that's why multicentric collaborations and international data sharing initiatives are so important. Always multicentric work. For instance, PRIMAT was a European multicentric project. So by pulling this data across institutions, we can create data sets that are larger and that are more representative. So I think that's the future, and that's what the way we have to follow. And regarding how difficult it's gonna be, I guess it's tricky because it's not easy. Each country has different regulations and regulatory, like bureaucracy. So it's not that easy. But there are projects that are achieving that. So these are barriers that are actually manageable. So yeah, I think the answer to these questions is multicentric collaboration, even in your country, in different hospitals in your city, or at a European scale. But yeah, I think this is the future of pediatric AI if we want to develop strong tools that we can actually use. I don't know if Brendan agrees, or what does he think?
Yeah. I was just going to come in to agree, which is that, you know, I think that the diseases that we're talking about are sufficiently rare that it is kind of international collaborations that are needed. And I think organizations, like if you're going to look at organizations to do that, I think EuSoMII and the ESPR are the really perfect place to start. It's obviously tricky. The question was about the sort of workforce challenges. There's so much pediatric radiology to be done. There's so many scans that need to be read and ultrasounds that need to be performed and images that need to be done. So the argument of paying someone to do these data sets and things isn't immediately obvious because because of the acute clinical need, and that's obviously really important. But I think both of us believe that that investing in this area is going to be worthwhile and it is going to bear fruit. So while it does take, especially in the context of the workforce issues, it does take a little bit of a leap of faith. But it we know that there's going to come a point, we're not there yet, but there will be a point where not using artificial intelligence is going to become unethical. It's going to get good enough that we have to use it. And I think it's part of our job to make sure that our youngest and our most vulnerable patients don't get left behind, because this is going to make a big positive impact in the near enough future. And it's our job as advocates for people who often can't speak up for themselves to make sure that children aren't left behind in the AI revolution. So it's a tricky argument to make, but I think it's worth making.
Thank you. Thank you. That was really good answers. I think that was actually the last questions, and that is actually good, because that leaves us, Alessia, with a few minutes. You had some reminders?
Absolutely, yes. So what I can see, like the last things, many compliments toward our speakers, because the attendees were thrilled by your presentation. So this is great, and we are very proud of what you did. So it is my pleasure now to share my screen. Yes, because what I wanted to remind you, okay, is that we will have another amazing webinar, AI in Cardiovascular Radiology. This is our next webinar on the 22nd of April. So you're all invited to register. You can scan this QR code. So you're invited to register and you're very welcome to take part to this webinar. Last but not least, this is our last QR code. So please scan it. It will be the best way to answer to the survey and you will obtain credit. If you're not able, do not worry, because you will receive in 24 hours your email and you can complete the survey in 1 week. So with these last tips and tricks, I leave the word to Lene.
Thank you, Alessia. Well, then all that remains for us would be to thank the speakers. Thank you, Diana Veiga-Canuto, and thank you, Brendan Kelly, to both of you for really brilliant talks. It's been very interesting, and we could clearly see and feel that you have been preparing well and collaborating. We know you both collaborate really well. And also thank you to all the attendees. It's great with all the participation and the questions that you bring along. So please continue to show up in these webinars. And again, we hope that you really enjoyed this on AI in pediatric radiology. There were a lot of good key takeaways, and I'm looking forward to hearing more from you in the future. So thank you so much to all of you, and remember to scan the QR code and then also register for the next webinars. Thank you so much.
Thank you very much. Thank you very much to everyone.
Thank you.